Additionally, what I would do in this case is I'll follow this to biopsy, demonstrate quickly our approach to biopsy. I think one of the things initially very important in performing breast MRI biopsy is to position the patient correctly. My personal bias is this is not something that the technologist should do. In our institution, the technologists get the patient in place and laying on the table, but then I always position the grids as well as the breast tissue. You're the one who knows best where the lesion is. You know the issues at hand insofar as getting appropriate compression to facilitate your biopsy. If there's an anterior lesion, you either position the patient appropriately, or if you have grids that are mobile, you can position the grids to more optimally compress the anterior breast versus the more posterior breast. This is somewhat of a mid lesion. It's positioned centrally within the breast. As we cross-reference, you can see it's pretty much centrally located within the breast. So in this case, you could do either a medial or lateral approach. In this particular instance, we chose a lateral approach. So once we have the patient positioned, we do a very quick localizer scan just to find the fiducials, perform an auto grid detection which overlays the grid, and then at that point we proceed to the biopsy. What we perform initially is we zero in on the area of the lesion with a fairly thin slab. This keeps our imaging times at minimal, so we can perform the biopsy very quickly. And then we display this in a 4-on-1 display, as you can see here. In the top left, we have our subtraction images, and then the series of pre, post, and post-obturator and subsequently post-biopsy automatically get laid on one another. So you can see here is our lesion in this area. There you see the pre-contrast, post-contrast acquisitions. Also see it in the axial projection. So as we targeted our lesion in this area and simply add a target, and then we're able to see where to place the needle both within the block as well as within the grid system. Having done that, the next step as you insert the trocar is place that. In this case, there was a fair amount of resistance, and so I advanced the trocar slightly greater than the 28 millimeters initially indicated, primarily for fear of tenting of the fibroglandular tissue. There, now you see the obturator in place, again here, and if you watch in the axial plane, you can see pre to post obturator, you can see that there is some tenting of the tissue. If we have it centered on the tissue before versus after, you can see it has in fact moved. I did advance it slightly more than indicated, and now the obturator is centered pretty much on the lesion. At this point, we performed a series of biopsies. You can see initially a cavity developed somewhat proximal to this. This is something not uncommon when you have an isolated lesion, particularly when it turns out to be malignant sitting within fat. Even though your sample tray may be centered appropriately, you'll see fat getting withdrawn just because of the density of the lesion. At this point, we did a half sample, so we were only sampling from the obturator distally, and then you can see now there is a cavity resecting the lesion in both projections. This did turn out to be an invasive ductal carcinoma. Our next patient will be continuing pretty much in the theme of high-risk screening. This was a 35-year-old female who had a history of premenopausal breast cancer in her mother. She had begun mammography 10 years earlier than the diagnosis of her breast cancer, but had recently, about 2 years ago, started high-risk screening with breast MRI as well. Her mammograms show heterogeneously dense tissue with multiple masses bilaterally. There's some scattered benign calcifications, but no malignant appearing calcifications are apparent. As we go to the breast MRI, I thought that it would be good to bring in sort of another extreme. You know, we've been showing cases that have fairly isolated lesions, not too difficult to find. I thought it only fair, though, to show the real world, and sometimes when you're faced with a case like this, when we look at your 1-minute subtraction MIP, again, the value of getting an overview, but this is going to be a difficult case. You know right off the bat there's tremendous enhancement diffusely of the fibroglandular tissue, multiple nodules, symmetrically, however, within the breast. First thing I would look at when I see a case like this is make sure that my scheduling department did their job and that this young woman is in the correct phase of her cycle. Since she is a high-risk screen, she should be around day 10, day 7 to 10 of her cycle. Additionally, in a different scenario, I'd want to make sure they weren't on hormone replacement. Neither of these were true in this case, and so then we're just faced with this really difficult appearance of the breast. The best way to approach this is, you basically have to analyze each lesion as best you can. Look for something differentiating from the rest of the nodules. When you see this diffuse multinodular enhancement, it, much like mammography, is often going to wind up being benign. But you obviously can't make that assumption, so you do have to analyze each lesion as you go through. The other thing is you can see here on the MIP, there's tremendous cystic changes within the breast. If we just on the fly create a 3D MIP, you can see the extensive cystic changes throughout the breast. Bilaterally, that accounts for the masses we've seen by mammography, but also, lends us to believe that this is going to be certainly some degree of fibrocystic change, but we still have the responsibility of trying to look for that nodule that's slightly different. As we go back then to the actual slice information, I won't go through my organized approach, just trying to get more cases reviewed here as we go from the pre to post contrast. Looking at these, the lesions, although several of them were larger, there are multiple of them. They're bilaterally located. We'll change the enhancement threshold a little bit here just to decrease some of the background noise, trying to find a more dominant lesion. But as we pan through, they're fairly uniform, but it's not just micronodular. These aren't foci. There's actually, scattered macronodular enhancements you can see. But in general, relatively uniform. One nodule is a little bit more prominent here. So we focus in on this. Still smoothly circumscribed. It does demonstrate some washout kinetics. If we cross-reference this with our other pulse sequences, you can see that on the STIR acquisition, this is relatively T2 hyperintense, as well as on the fast-spin echo T2 acquisition is T2 hyperintense. So this is, I'm feeling pretty good about this being likely a fibroadenoma. And as we reviewed this, we didn't see any dominant lesion that stood out. But in this instance, I think you pretty much have to communicate that the degree of background enhancement significantly is going to limit the sensitivity of this patient's exam. Depending on the mammogram, we will sometimes recommend a 6-month follow-up mammogram, and really the purpose of that is to make sure that everything appears stable, and then you have to rely on a 1-year follow-up MRI to determine, has anything changed, at which point then you might be led to intervene and perform a biopsy. But this is a very difficult case, there's no doubt about it, but the symmetry of enhancement, the bilaterality, is generally speaking for benign, but I use this as an example to illustrate the point of sometimes you have to note that your sensitivity has been hindered and rely on a follow-up to look for stability. This patient has been followed since 2007 now, and so far everything has remained stable. Our next case is a patient in her late 40s who presented for a routine screening mammogram. On the mammogram, which I just show a couple of magnification views, there was a cluster of abnormal microcalcifications within the breast. There were no additional significant calcifications noted, although the patient did have moderately dense tissue. This patient underwent a stereotactic biopsy, which did reveal ductal carcinoma in situ, and came to MRI to assess extended disease prior to her surgery. Here, following again with our initial overview on the 1-minute subtraction MIPS, a moderate degree of background parenchymal enhancement, fairly symmetrically, but clearly there's a significant amount of asymmetric abnormal mass-like and non-mass-like enhancement within the right breast. Obviously, a very concerning appearance in this patient. Again, just looking through, we won't create the significant images just for the sake of time, but looking at these images, there's clearly multifocal tumor here, likely areas of invasive, but then this non-mass-like intervening enhancement, very commonly associated with DCIS and often relatively high grade. There's a solitary focus remote in the lower outer quadrant of the right breast, and the left breast demonstrates pretty much just normal parenchymal enhancement. One nodule here, which we did analyze, circumscribed, demonstrates non-enhancing internal septations and T2 hyperintense signal, compatible with a fibroadenoma. To look at this in more detail, we'll switch to the 2D images. And again, beginning medially and stepping through sequentially. You can see a spiculated mass here with rim enhancement, some degree of plateau kinetics, another discrete mass here, a little bit lobulated, not clearly spiculated in its margins. Here, a very classic appearance for cancer. Just for the sake of a further evaluation, if we cross-correlate these, here you can see on the delayed exam, this abnormal enhancement with the delay, you've lost some of the morphology as the lesion has started to wash out and the margins become less distinct. This is clearly not T2 hyperintense, not that that would matter given this morphology and the enhancement characteristics of this. In this instance, you would obviously segment some of these lesions. In this case, I will just segment two of the more dominant lesions. And this obviously for BI-RADS classification would be a BI-RADS 5. But in this case, you can see a tremendous benefit from this patient's MRI, showing extensive disease that was not at all suspected previously. The question comes up is, what about this nodule that's in a remote quadrant here? It has fairly non-aggressive enhancement characteristics. Cross-referencing this, this is an area that's hyperintense and T2 signal. I can't make out lymph node morphology. And this would be a difficult call here on this delayed acquisition. Lesion looks somewhat irregular in its margins. If this patient is planning on breast conservation, then I think this would warrant an MRI-guided biopsy to make sure you weren't dealing with multicentric disease. In this patient's case, she did elect to proceed with mastectomy, which did demonstrate multicentric invasive ductal carcinoma with large areas of intervening DCIS. Our next patient is a 61-year-old female who presented to her surgeon with breast pain and swelling and redness and clinical findings compatible with inflammatory breast cancer. Her mammogram also supported this, showing asymmetric increased density of the tissue in the right breast as well as skin thickening. She came to MRI for pre-chemo evaluation, so I wanted to take an opportunity to show these images because it shows some of the classic findings of inflammatory breast cancer. Here is the breast MRI exam, again from the initial 1-minute subtraction MIPS, a normal appearing left breast, obviously early phase imaging with a prominent vascular enhancement, and clearly diffuse abnormality throughout the right breast. In this case, with clinical inflammatory cancer, this does demonstrate actually an underlying discrete mass. As we look through with the thin MIPS, you can see this large spiculated area, somewhat mass-like with a large surrounding volume of non-mass-like abnormal enhancement within the right breast. The other thing to notice, though, is the thickening of the skin as well as enhancement of the skin. Let's go to our detailed imaging with the actual slices and on our subtractions. And if you look, you can see this large area of non-mass-like and more overtly mass-like enhancement underlying this case of inflammatory cancer. But then if you look carefully, you see this abnormal, somewhat irregular and interrupted enhancement of the skin. This is a characteristic finding with inflammatory breast cancer. Not real commonly seen. I've had cases of inflammatory breast cancer that didn't necessarily show this, but when you do see this, you can be pretty confident of the diagnosis. You can see on the STIR imaging the pronounced edema of the breast. Displaying this in a MIP representation, you can see the pronounced asymmetric edema throughout the right breast. And this patient did undergo percutaneous biopsy confirming invasive ductal cancer. Biopsy of the skin did also, however, confirm the angiolymphatic invasion of the skin. In this patient, just to show an example, there's nothing subtle about this, but as we look at our T1 images, you can see this pronounced pathologic lymphadenopathy of the level 1 axillary lymph nodes of the right breast. So this is just a nice example. You can see here the spiculated mass of the characteristic findings of inflammatory breast cancer. Well, that's all the time we have today. In this fairly brief period of time, I hope I've been able to give some overview on the topic of breast MRI, as well as demonstrate some individual features on establishing a breast MRI program, as well as an approach to actual case interpretation. I hope you found something useful, and I thank you for your time.